The following program is sponsored by the Medicine Center Pharmacies.
Good morning and welcome to Health Matters with the Medicine Center Pharmacy, a local Health Mart pharmacy. I'm your pharmacist, Paul White. We're glad you joined us. Before we begin, I'd like to thank our sponsors, Studio Arts and Glass, Kiko Auctioneers and Realtors, and, of course, our technical producer, J.D. DeAngelis. In the studio with me is Nancy Warmby, Executive Vice President of Medicine Center Pharmacies, and our very special guest, Dr. Rishi Goel, Neurosurgeon at Aultman Medical Group. Good morning, Doctor, and welcome to the show.
Good morning. Thank you for having me.
Often, when you think of neurosurgery, many people think of issues involving the brain. However, neurosurgeons diagnose and treat issues beyond the brain. Some conditions that might warrant treatment from a neurosurgeon include carotid artery disease, cervical spine disorders, chronic pain, stroke, and nerve and head injuries, among others. Today, we're going to talk about types of disorders and their treatment associated with neurosurgery. We'd like to remind you that today's program is also available on our podcast, which can be downloaded from the App Store on your mobile phone. Look for Health Matters with the Medicine Center Pharmacy, and you can listen to any of our programs anytime. If you have questions you'd like addressed during the program today, post them on our Facebook Live video or call us at 330-450-1480.
So, Dr. Goel, can you tell our listeners where you currently practice as a neurosurgeon, where you came from, and why are you here from California?
Sure. So I was born and raised in California.
Okay.
So I started off there. I went to UCLA. I did my undergraduate training there. And I double majored in neuroscience and economics. And then after that, I went to med school at the George Washington University in Washington, D.C. So I managed to live on both coasts for a while. And then I matched in the neurosurgery department at University Hospital's Case Western Reserves. I did my training there. And then when I finished my training, I actually stayed at University Hospital for a number of years. And now I'm new to the area here in Canton.
Okay. So how long have you been here?
I have been here for about 7 months now.
Okay. So you got to experience winter.
Yes, I did.
It's not gone yet. So I would think that neurosurgery would be a lengthy specialty.
It is. It's one of the longest residencies. So the average neurosurgery residency is about 7 years. And a lot of residents will elect to do additional training either during their residency or afterwards in what's called a fellowship. So they'll subspecialize within neurosurgery.
Okay.
And there's many different fields that can be done, and that can be done in vascular, skull-based anatomy, tumors, pediatric neurosurgery, spine. So there's many different options that are available.
I would guess that most people think of neurosurgery as someone who operates on the brain, but that's not the case, is it always?
No, that is not always the case. So we cover the brain and the spine.
Okay. So it would not be uncommon for you to be in the surgical theater with someone, what do we call them? I guess not neurosurgeons. We would call the other doctor in there operating on the spine.
Orthopedic surgeons.
Orthopedic.
Correct. So our
that
training...
that would be the only other practice that would be operating on the spinal area, right?
That's correct. It's either us or ortho.
Okay.
And so the general overlap is that orthopedics tends to involve more bone work. Okay, so if there's arthritis in the spine caused by compression of bone or compression of a disc, an orthopedic surgeon and a neurosurgeon can do that. The difference is that if there's, say, a tumor of the spine, then that's going to involve a neurosurgeon. Or if there's a tumor of the actual nerve itself, that's going to involve a neurosurgeon. So we have to know everything orthopedic surgeons know in terms of doing all the bone work, plus then beyond that in terms of operating on nerves potentially, or even the spinal cord.
Okay.
So that's where there's that initial overlap and then the additional depth for neurosurgery.
We may have just answered all three of the questions that you are next on the schedule.
I think so too.
One question we didn't ask it.
Well, I think the point of the next couple questions is talking about your training and your board certification and how long it takes. So whatever you'd like to share with our listeners would be good.
Sure. So as I mentioned earlier, my training was 7 years. So I started my residency in 2003, and I finished in 2010. I did additional time for neurocritical care, so treatment of patients in the intensive care unit, as well as doing minimally invasive spine surgery. So that is one of my main interests.
Oh.
So
that's your subspecialty.
That is one. Yes.
Okay. Very good.
How does economics fit with the neurosurgery?
Well, the thing was that in college I wasn't quite sure. So I was like, well, should I go to law school or should I go into medicine? And so I decided to hedge my bets and then major in both. So I had a double major both in econ and then in neuroscience. So
too many attorneys, not enough neurosurgeons.
possibly. I know my econ professors were a little upset that I didn't go into law school.
Oh.
Funny that. So, okay, I sort of asked this question before, but I'm going to follow up a little bit different. Operating on the brain, I know, is extremely difficult because you destroy so much tissue if you have to go deep in the brain.
Correct. That can be a destructive process.
Okay.
There are new technologies that allow us to image where we are going in the brain in 3 dimensions. So there's something that's called navigation. So what we can do is, let's suppose there's a tumor that is deep-seated in the brain.
Like behind the optic nerve or something
Perhaps
like that?
behind the optic nerve, or let's say on the left side of the brain, which is for greater than 95% of people where speech is located.
Mm-hmm.
And the question that you have as a neurosurgeon is, okay, I want to take this tumor out, but I want to take it out as safely as possible. Where then is this patient's speech located in relation to this tumor?
Okay.
All right, because let's suppose you're in the operating room and your patient's asleep. You can clearly see the tumor, but when you take it out, your patient wakes up and they can't talk anymore. Right? So that can be a disaster. So what you can do is you can obtain what's called a volumetric MRI, which is basically an MRI that allows you to reconstruct the brain in 3 dimensions in the operating room. So you can see exactly where your instruments are in relation to the tumor. There's also another MRI that's called a functional MRI, where while the patient's in the MRI, you can ask them questions like, say, tell me the alphabet, or you hold up flashcards with pictures on them. And so the areas of the brain that are responsible for speech light up on the MRI. And then you can fuse those 2 MRI images together. So now you have a 3D reconstruction of the tumor, and then you also have a picture of the MRI that shows you where the patient's speech is. So that while you're resecting the tumor, you can test. It's like, okay, I know speech is located here. Here's the tumor. I want to stay away from this area and concentrate my resection here.
Well, how do you, don't you anesthetize this patient?
Yeah, so there are
still
more
asking him questions.
No. So those questions are being done during the functional MRI. And then
okay.
when they're in the operating room, there's
Okay.
you can actually do the surgery with them fully asleep, which is what we typically do.
Okay.
Or if the tumor is located directly in either the motor area or speech, you can actually do the surgery with the patient awake.
Very interesting.
So you can ask them to say their ABCs, or if they're a musician, play their instrument, and then while you're resecting tumor, you can see if you're affecting speech. The brain, fortunately, whoever designed us, whoever engineered us, was kind. The brain does not have pain receptors. So while you are resecting a tumor, the patient is not experiencing pain. Now the scalp and the skin has pain receptors, but you can put local and anesthetize that.
Geez, that's very interesting.
Wow.
Recently, a friend had serious headaches, couldn't figure out what it was, and they did find this tumor at the back of the optic nerve. And what do you do with that?
So first thing is that you'd probably have to do a formal visual field assessment to see how much vision is actually in that eye. Because a question that you're going to run into during surgery is, if you cannot resect that tumor completely, if you cannot separate it off the optic nerve, like there's no nice plane, there's no nice division between the nerve and the tumor,
Sure.
can you sacrifice the optic nerve? Okay, so you want to document what is their vision. If they're blind in that eye, or if they've lost near complete vision in that eye, then you're more likely going to say, well, the optic nerve may need to be sacrificed. But if they have perfect vision and all they had were headaches, then you really want to focus on perhaps leaving some tumor behind in terms of sparing the optic nerve.
Can you radiate it or anything like that? Or?
It depends on how far the tumor is from the optic nerve. Radiation is an excellent therapy, and we have something called gamma knife, which I'll talk about. But the problem with radiation is that it doesn't have clear margins. You can target a tumor with what's called gamma knife or radiation therapy, but some of that radiation will spill over. It'll go onto adjacent structures. So if that tumor is sitting right onto the optic nerve, even though you're targeting the tumor, some of that radiation will spill over onto the optic nerve, and then you have to see, well, are you causing more harm than good? So you have to evaluate all these things prior to even making any incision. So then that usually involves a discussion with the radiation doctors and planning what would be the appropriate dose, how much spillover will there be.
Okay. Early in my career, we had this customer come into the drugstore, constant migraine headaches. Tried everything. They've had them on narcotics, and at that time there was even less worry about too many narcotics.
Sure.
Turned out that after much physician visits and dentists and all, the nerve of the tooth had grown around the optic nerve. Isn't that? I mean,
That is very unusual.
isn't that strange?
That is very strange.
I mean, I the other pharmacist I was working with sort of interviewed him after that all happened, and he told me this story. I thought, come on, you got to be kidding me. But it was actually curled around them.
One ended up happening with it.
So I don't know what they did. I guess they got it out of there somehow.
Okay.
It didn't. His vision was both eyes afterwards.
All right.
Never seen that before.
To be honest, not in that presentation. There are a number of neurologic conditions that can cause facial numbness or facial pain, and oftentimes that's caused by a tumor near the brainstem.
Okay.
Or that can also be caused by a blood vessel that might take a slightly unusual course than normal, and then with each pulsation, so with each heartbeat, it might be hitting the nerve root right behind it. And so sometimes what we have to do is we have to identify that artery is taking a rather unusual course instead of its normal course, that is taking a little loop and might be hitting the nerve. And then what we do is we don't sacrifice the artery, but what we'll do is we'll put a little bit of what's called Teflon. It's almost like cotton in between the artery and the nerve. So that as the artery is expanding and beating with every heartbeat, it's no longer putting pressure on the nerve root, and the patient's pain is eliminated because that nerve isn't being irritated anymore.
Does robotic surgery usable in any neurosurgery?
So currently for the brain, no. The research that's being done right now is robotic-assisted surgery for the spine. And what that means is basically using three-dimensional navigation and robotic surgery to insert screws into the spine with less deviation, more accuracy, to make sure screws are going into the right parts of the bone. So there's a lot of research that's being done with that and image guidance.
You know, one of the things that we mentioned in the intro was that neurosurgeons can also treat strokes.
That is true.
What type of strokes or what situations would warrant that?
Okay, so in general, we can divide strokes into two categories. One would be an ischemic stroke. The other is a hemorrhagic stroke. So an ischemic stroke in general is where an artery in the brain can get clogged off. And then what happens is that the brain tissue past that artery starts to lose blood flow, it starts to die, and then it starts to swell. Okay? And so that's when you can get patients who can either end up with they're not able to talk or they're paralyzed. So this becomes kind of a surgical emergency. So the first treatment algorithm would be, if someone's coming in with signs of a stroke, is you get a head CT. Because you want to make sure that you rule out a hemorrhagic stroke. Because if they're bleeding, the treatment algorithm is completely different than if they're not bleeding. Because obviously you can't give blood thinners to someone who's bleeding in the brain. You'll make the bleeding significantly worse. So that's the first sort of decision algorithm. That's the first branch point. So if they are not bleeding, there's no blood in their head CT, then you get a study of the blood vessels to see which one is clotted off. If it's one that's big enough that you can, say, put a catheter, kind of what the heart doctors do where they do a cardiac stent, we can do something similar with the brain. So we can actually put a catheter into the big artery in the leg, kind of roto-rooter that up through the heart into the brain, and then release either clot-dissolving medication into that artery to dissolve that clot, or we can also do what's called a mechanical retrieval, where we can insert it's almost like a wire brush, and it grabs the clot and it pulls it out so it reopens the blood vessel, and you can restore blood flow. So those are some of the things that we can do as neurosurgeons for ischemic strokes.
You know, in this month's, believe this or not, in this month's National Geographic, I'm still one of those guys that gets the magazine. The title on the cover is "The Future of Medicine" or "The Future of something related to medicine." I can't remember, but they do show. We've talked about on this show many times about the Da Vinci robots, and there is a picture, like a whole full fold-out picture of the Da Vinci robot on a patient.
Sure.
Better than I've seen a picture of, I think, anywhere. But it goes through all where supposedly where we're progressing in medicine and that sort of thing. It's really quite interesting.
Right. More and more medicine is becoming less invasive and less destructive to the tissue. So, for instance, that procedure that I mentioned for the ischemic stroke, that wasn't around, 15, 20 years ago. Before, we would try and give that patient just medications to try and dissolve the clot, and if it worked, it worked. If it didn't, it didn't. But now we can actually go in there and directly dissolve the clot or physically remove the clot from the artery and restore blood flow.
Interesting. Tell you what, Doctor, our first break is here. You're listening to Health Matters with the Medicine Center Pharmacy.
You're listening to Health Matters with the Medicine Center Pharmacy and your hosts, pharmacists Paul White and Brad White. Remember, you can get more information right now by visiting medshoprx.com. That's medshop.rx.com. We'll be back with more of Health Matters with the Medicine Center Pharmacy in just a moment.
Hi, this is Brad White, your Medicine Center pharmacist. Are you paying big bucks for a little blue Viagra pill? There's a better alternative. Starting at only $4 per dose with a prescription from your doctor, the Medicine Center Pharmacy can prepare a sildenafil or tadalafil tablet that melts in your mouth for an affordable price. This allows you to take care of business and still have money left over for dinner and a movie. The Medicine Center Pharmacy has 4 locations in Stark and Tuscarawas counties. We're here to keep you healthy and save you money. Give us a call at 330-339-4466 for more information.
With a heart attack, every second counts. Every moment the blood supply to your heart is cut off or reduced leads to heart damage or death. Mercy Medical Center can stop a heart attack in record time. Mercy is the only hospital in the nation that can open a blocked artery right in the ER just minutes after arrival, saving lives and preventing further heart muscle damage. That's because Mercy's Emergency Chest Pain Center was America's first to achieve full accreditation and the first to install a fully functional cardiac catheterization lab just a few steps away from our ER doors. The average time in the U.S. from ER arrival to opening of a blocked heart artery is 64 minutes. At Mercy, thanks to our ER cath lab and the area's most experienced emergency heart care team, it's faster. We're capable of opening a blocked artery in as little as 5 minutes. If you have heart attack symptoms, get to Mercy. We can stop a heart attack in record time. To learn more, visit cantonmercy.org/heart.
Brighten your day with beautiful stained glass from Studio Arts and Glass. Let the sun shine in through a stunning beveled glass window that forms a rainbow on your walls. Commission a piece of art to cherish for years. All at Studio Arts and Glass on Apple Grove and 77 in North Canton. Open Monday through Saturday, 10 to 6, or shop online at studioartsandglass.com. That's studioartsandglass.com.
It's winter weather season, which means dry, irritated skin can be a problem. Medicine Center Pharmacy can help you stay moisturized for less. Save on our Quality Choice line of products during our buy one, get one free sale. The Quality Choice brand is the same as national brand items, but without the price tag. Stop into any Medicine Center Pharmacy and stock up on all Quality Choice products, including skincare, cold and flu remedies, feminine products, and more. Mix and match all Quality Choice and save big. Free item must be equal or lesser value. Visit medshoprx.com for more information. Welcome back to Health Matters with the Medicine Center Pharmacy. Today we're talking about neurosurgery with Dr. Rishi Goel with Aultman Medical Group. Have a question, post it on our live Facebook feed or give us a call at 330-450-1480. So, Doctor, tell us about some of the procedures that you have done or that you do. I guess this isn't routine surgery.
Sure. So I'll give you an example of a few cases, if I may. So there was a gentleman who was unfortunately involved in a car accident. And so this is a trauma case. Now, the injury was significant impact whenever he came into the hospital. He had a large blood clot putting pressure on his brain. So that's called a subdural hematoma.
Head issue.
Right.
Yeah.
So for that case, what I had to do is remove almost half of his skull, take the blood clot out, find what was bleeding, take care of that, and then during surgery evaluate essentially, can I put his skull back on? Right? Because when we're adults, our skull is fused. Right? It's not like we're babies where, you have the fontanelles and the soft spots, because if a baby's brain starts to swell and their bones aren't fused, the skull will actually get bigger to accommodate that pressure. But as an adult, that's not the case. So if there's bleeding in the brain and the skull cannot expand, you will get an increase in pressure, right? Yeah. And that pressure can only go one place. It can either cause, say, the left side of the brain to shift to the right, it can cause the right side of the brain to shift to the left, or it can cause things to shift.
So what you're saying is it's soft on the side of the head, no? As an adult, but not soft anywhere?
As an adult, no, your skull is fused.
Okay, so it doesn't expand on the side at all either.
There's no expansion. So if you have any bleeding or any pressure, say from a tumor, trauma, brain swelling, or a blood clot, you're going to increase pressure because your skull can't get any bigger. So worst case scenario is that pressure is directed downwards towards the brainstem. Now the brainstem's job is basically to keep you alive. It regulates your heart rate, your blood pressure, your breathing, your level of consciousness. If the brainstem undergoes pressure, that can be fatal.
Okay.
So that's why we have to move these clots rather quickly, because time is an issue. So during surgery, we are always wondering, okay, we've taken the clot out, we've identified what's bleeding. Is the brain expanding rapidly outwards? Can I put the skull back on safely? Sometimes you can't. Sometimes you have to leave the skull off.
Wow.
So that you buy that patient some additional room to expand outward, which is safe, as opposed to downward, which would be pressure directed on the brainstem. And most people's skulls are about 1 centimeter thick. So that's maybe like half an inch, or so you can buy them that additional space to expand outwards. So those are questions we have to ask ourselves.
So on a subdural hematoma, is it liquid or is it solid, or both?
So it can be any one of those three.
Okay.
So if the blood is fresh, it usually is thick. Okay, so think of fresh blood, and forgive my analogy, as strawberry jam.
So you could stick a needle in there and pull it out?
No, because you can't get strawberry jam out through a needle. It's too thick.
Not even a big needle.
Not even a big needle.
Okay.
So for that, you have to cut through the skull and physically wash it out, or kind of scrape it off of the surface of the brain.
Wow.
Now, old blood is like very liquidy. So here's another analogy. Think of fresh blood as an ice cube. It's more like a solid, okay? But think of old blood as that same ice cube that's melted. Okay, so it becomes liquid. You go from solid to liquid. So as the blood is breaking down, it'll become more liquid. Now, sometimes in some people, that blood clot can actually be reabsorbed by the brain because now it's liquid. In other people, it can't. And then you have to balance that, because as you're going from a solid to liquid, that ice cube, as it melts, takes up more space, right? So it's the same thing with blood. From fresh blood to old blood, as it dissolves, it actually can get thicker.
So let's go back for a second to the gentleman that you were deciding whether or not you were able to put the portion of his skull back on.
Right.
If you can't, what do you do? Can you ever put it back on?
Yes, you can. So if during the surgery you decide that it is not safe to put the skull back on because the brain is expanding past that margin of the outer skull layer, then you just close the skin. You close the skin over that, and then you wait. Sometimes it takes up to 3 months before the brain swelling goes down before you can put the skull back on. But typically what we'll do in the hospital setting is we'll give that patient medications to reduce brain swelling. So we'll give them what we call diuretics. Or basically what we'll do is run essentially salt water through their veins so that we can draw out the water from their brain into their veins, and then they'll essentially urinate that out. So we're kind of drying them out to decrease the swelling of their brain. We'll also sometimes just chemically sedate them, because if their brain is not metabolically active, then the blood flow and the metabolic demands decrease, and that also decreases swelling because it's not active anymore. So essentially put them in a chemically induced coma to also reduce swelling.
Wow. Okay, we got to interrupt this discussion. I'd like to get back to this when we come back, okay? It is the bottom of the hour and time for the news. Thanks for joining us this morning on Health Matters with the Medicine Center Pharmacy.
You're listening to Health Matters with the Medicine Center Pharmacy and your hosts, pharmacists Paul White and Brad White. Remember, you can get more information right now by visiting medshoprx.com. That's medshop.rx.com. We'll be back with more of Health Matters with the Medicine Center Pharmacy in just a moment.
Hi, this is Brad White from the Medicine Center Pharmacy. Perhaps you've gotten the urge to venture outside and clean up the garage or do some yard work, resulting in muscle aches and pains. If you have sore muscles or aching joints, you may want to consider a prescription pain-relieving cream available with a prescription at the Medicine Center Pharmacy. Our pharmacists can work with you and your physician to get topical pain creams that can be rubbed directly on the source, reducing inflammation and pain. Topical creams avoid troublesome side effects and dependency issues that can be caused by oral medications. The Medicine Center Pharmacy has an accredited compounding laboratory, and it is your source for custom medications. Custom compounded pain-relieving creams, available only at the Medicine Center Pharmacy, where wellness begins. Visit us at medshoprx.com for the pharmacy nearest you. That's medshoprx.com.
Brighten your day with beautiful stained glass from Studio Arts and Glass. Let the sun shine in through a stunning beveled glass window that forms a rainbow on your walls. Commission a piece of art to cherish for years. All at Studio Arts and Glass on Apple Grove and 77 in North Canton. Open Monday through Saturday, 10 to 6, or shop online at studioartsandglass.com. That's studioartsandglass.com.
You won't want to miss this upcoming Kiko Absolute Auction Saturday, February 23rd with auctioneer Bill Gill Jr. It's a sports memorabilia extravaganza with more than 90 autographed jerseys from greats like Hank Aaron, Michael Jordan, LeBron James, and Cal Ripken. You'll also find autographed photos and posters by celebrities like Megan Fox, Ariana Grande, John Glenn, and more. Sports cards, comics, magazines, mini helmets, NASCAR collectibles, and more are available for bid this Saturday, February 23rd at 10 a.m. at 3201 Parkway Street Northwest in Canton. Call Bill Gill Jr. at 330-455-9357 or visit KikoAuctions.com. Are you tired of paying hundreds of dollars to find out your A1C and cholesterol levels? You don't have to do that anymore. Every month in each of our pharmacies, you can get your A1C lipid profile, which includes your cholesterol levels as well as glucose results, while you wait. A Medicine Center pharmacist will draw your blood and give you the results in just minutes. You can also get your blood pressure checked for free. Call us to find out when we'll be in the Neighborhood Medicine Center Pharmacy in Canton, Louisville, Minerva, and New Philadelphia. 330-454-8772. You're listening to Health Matters with the Medicine Center Pharmacy. I'm your host and pharmacist, Paul White. Today, Nancy and I are talking about neurosurgery with Aultman Medical Group's Dr. Rishi Goel. We've got a lot more to cover this morning, so let's get back to the show.
Paul, before we continue, we did have a caller from Canton who says if a person has been a blood donor, would this cause complications before, during, or after surgery?
No, it absolutely would not. I'm a blood donor myself, too, and I've been a recipient of blood as well. It does not cause any problems.
Sure. We were in the middle of a discussion of what a neurosurgeon actually does, and we talked about the brain. Now we got to drop down to the spine.
Sure.
Not that it isn't a part of the brain, but anyway.
Sure, so one of the most common procedures that I like to do are minimally invasive spinal surgeries. And so traditionally what's been done in the past are what we call open procedures. So let's suppose someone has arthritis in the back or a herniated disc. Then oftentimes the incision that you would need to make for that might be anywhere between 3 to 5 inches or even longer. Nowadays, with this new technique, we can oftentimes make an incision that's maybe 3/4 of an inch and accomplish the same amount of work and do the same amount of technique through that incision and have the patient go home an hour after surgery with a significantly reduced risk of infection, less pain, less blood loss, and earlier return to work.
So you see all this advertising on television at some spinal institute somewhere, and they operated on this girl in a bikini, and you can't even see the scar.
Right.
Is that what we're talking about here?
That is what we're talking about. Now,
okay.
I have to say, though, the name is a slight misnomer because, the Laser Spine Institute, right? I get this question asked at least maybe 10 times a week in the office where patients are asking me, Dr. Goel, are you using a laser like the Laser Spine Institute in your surgery?
Yeah, okay.
And the answer to that question is no. Their name is the Laser Spine Institute, so they're not using a laser. It would be as if my name were Dr. Laser instead of Dr. Goel.
So it's a misnomer.
That's all that it is.
Okay.
It is whoever their marketing person is truly brilliant because people think that they're using a laser.
Hey, I did.
And what I like to tell patients is that, now, are there lasers that we can use in spine surgery? Sure, absolutely. Here's what we use them for. Let's suppose someone has, say, kidney cancer that's spread to the spine, or melanoma that's spread to the spine. Well, those tumors bleed a lot. And by a lot, I mean if you're not careful, your patient can bleed out on the table a lot. So for those cases, sometimes what we'll do is we'll use a laser to help cauterize and stop the bleeding in that tumor because the bleeding can be so excessive. Barring that situation, would you want a hot laser that can slice through anything in milliseconds near your nerve? No, you wouldn't. Right? So it's strictly a name.
A Laser Spine Institute. Huh? That's nuts.
Right, but it's the same techniques as minimally invasive spine. So when you see that young woman, out in Tahiti with the little Band-Aid on her back, that's minimally invasive spine surgery, which is what we are doing here at Aultman.
I love it.
So in that situation, people are paying attention to the commercials. So between commercials, social media, and everything that we can learn or mislearn from the internet,
correct.
What recommendations do you have for people who are searching for answers, hoping for cures, etc., by doing their own research?
Well, I would say this. It's always smart to be an educated and well-informed person. However, you will find anything you want to find on the internet. Mm-hmm. You will find positions pro certain issues. You'll find positions against certain issues. So whatever you're looking for, you will find. The best advice that I can give is, if you're an internet research-based person, take what you found. Go talk to your doctor and ask him or her the questions. Mm-hmm. And they'll tell you what's the right answer. And if you want, get a second opinion. Anytime I operate on any one of my patients, I always ask them, do you want a second opinion? If you do, I will set it up for you. Because my patients, I tell them, you're allowed to disagree with me. I'm giving you my recommendations based off of my experience. I'm telling you what I would do for you. But if you'd like a second opinion, I'll set it up for you.
Interesting. So there must be some sort of standards in the type of surgeries you do. I mean, okay, this is the way you do it. You don't do it this way. Yes, I mean, this is
not
we're
really.
You're wrestling with the electrical system of the body,
right? So standards would imply that you could get 100 physicians or 100 surgeons in a room and have them agree on one thing, and all come up with a cohesive decision. And unfortunately, that's not the case. If you get 100 surgeons in a room and ask them a question, you'll probably come up with 10 different answers, because there's more than one way to skin a cat, right?
Yeah.
So it all just depends on, do you go anterior? Do you go posterior? Do you go anterior and posterior? Do you open? Do you minimally invasive? And the vast majority of the time, it depends on what was your surgeon trained in, right? Because if they're only trained in open procedures, then that's what they're going to recommend, right? If they're trained in open and minimally invasive procedures, which is what I was trained in, then I base my decision based off of what's safer for the patient. What's the anatomy of the patient? Because if the anatomy of the patient means that, let's suppose I'm doing a 5-level decompression. So I'm decompressing the lumbar spine from bone number 1 down to bone number 5. Well, in that case, a 1-inch incision is not big enough to make that decompression. You have to do it open. But let's suppose a patient has, say, a single-level disc herniation in between bone number 4 and 5. Well, in that case, I'm recommending a minimally invasive procedure and coming down right onto the disc with that 1-inch incision, and that patient's going to go home an hour after surgery. So then for me, because I'm trained in both, I use the patient's anatomy to dictate what's safer for them.
So Rhonda Chellis had a hip replacement. What's the neurological involvement? Probably shouldn't have mentioned the name. What's the neurological involvement here? I mean, neurosurgery have anything to do with these replacement therapies?
So by replacement, if you mean by hip replacement, for the spine, not necessarily, because I can't replace someone's bone in their spine. I can't take out a bone and replace it with a synthetic bone. What I can do is I can fuse someone. So let's suppose someone falls off a ladder and they shatter a bone in their spine. Okay. So now they don't have stability in their spine. When it comes to the spine, there's always two big questions. Is the spine stable? And is a nerve being compressed? So do I need to take bone off to decompress the nerve? And do I need to add bone or add hardware to stabilize the spine so that the spine doesn't move in ways it's not supposed to? Okay. And those are called pedicle screws or fusion. That's when we talk about that. Now, the good news is that a lot of those fusion cases can now be also done minimally invasive. So I can make a 1/2-inch incision and put a screw in someone's spine.
Amazing.
So we have some questions on here, and I'm not sure I'm going to pronounce this correctly.
All right.
But what is a glioblastoma?
Glioblastoma.
Okay.
So that is a primary tumor of the brain. And by primary, I mean that when it comes to tumors of the brain, there's always a question your physicians are trying to answer is that tumor from the brain tissue itself, or did it come from somewhere outside the brain and spread to the brain? So by primary, I mean that it's arising from the brain tissue itself. It is a type of brain cancer. And unfortunately, it is the most malignant, and it's also unfortunately the most common.
Why do we get this?
So we're still trying to figure that out. Sometimes it's, there's theories that it could be genetics or it could be exposure. We don't have a good solid answer on that. But I can tell you the treatment typically involves either surgical resection or chemotherapy or radiation a combination of any one of those, or where a lot of the research is going now is in terms of immunotherapy. So using the body's own immune system to try and target those cancer cells and have our immune system kill those cancer cells. Because unfortunately with GBM, it's not as if there's a definitive margin between the tumor and the brain. That tumor infiltrates into the brain. So even if you think, okay, I can clearly see that this is abnormal tissue and that looks like normal brain tissue, from your naked eye, that might look like there's a plane there. But what our studies have shown us is that there's already little cells of that tumor that have already gone into the normal brain, and they'll start growing more tumor there. So how I was trained was that if you are operating on GBM, if you don't think you can safely take out at least 95% of that tumor so that you reduce how much is left to be treated with radiation or chemo, then it's as if you didn't operate at all. Because that's how aggressive it can be.
Wow. Where are they likely to be? Any particular part of the brain? Or?
It can go to any part of the brain.
Okay.
John McCain, is that what John McCain had?
Yes.
That's right. Yeah.
Amazing.
So hopefully the new research will allow for us to use our body's own immune system.
So one question that we've asked other physicians that we've had on the show, and it's not in our script for today, but what symptoms or concerns might any individual have that would trigger a thought that perhaps I need to see you?
Okay, so let's divide that into two categories. So we'll answer that question for the brain, and then we'll answer that question for the spine. Okay. So for the brain, if someone's having, say, sudden onset of the worst headache of their life, right? So we call that a thunderclap headache, where they might be just watching the game, and all of a sudden they get, in a split second, the worst headache of their life. We tend to worry about an aneurysm that may have ruptured. Okay, so that would be one symptom. Let's suppose someone's coming in with facial numbness or arm numbness, or they're having difficulty talking. All right, so we call that the FAST sign, right? So face, arm, speech, and then timing, right? So in that case, you want to come to the hospital and get a head CT, because now any one of those, either a tumor or a stroke, can cause any of those symptoms. So if you're starting to have anything involving your face, numbness, tingling, weakness, arm, numbness, tingling, weakness, or speech, problems either understanding speech or problems producing speech, you need to come on into the hospital and get evaluated at a bare minimum with a head CT.
Okay.
So that's sort of with the brain in general. Now, for the spine, if we break it down into, say, arms and legs, so if someone's having, say, neck pain with, what we describe as sciatic pain, that electric-like stabbing pain shooting down either arm, they should be evaluated. And it's the same exact thing for the legs. If someone's having back pain and they're having that classic sciatic pain, oh, hey doc, I'm having pain that goes down the back of my thigh, the back of my calf, and it's like someone's poking me with a hot electric knife, you should be evaluated. Now, 9 times out of 10, that might just be nerve irritation. Like they might have been gardening the day before and they caused some stress on their nerves, and most of the time we can treat that conservatively, either with things like ibuprofen, Tylenol, maybe some steroids for them to go home with, and some muscle relaxers, and rest. And most times that gets better. But if it's persisting beyond that, then they might need an MRI of either their neck or of their back, or we might send them to physical therapy or to see our pain management doctors, and they can do an injection of steroids right on top of the nerve root.
Final break is here. You're listening to Health Matters with the Medicine Center Pharmacy.
You're listening to Health Matters with the Medicine Center Pharmacy and your hosts, pharmacists Paul White and Brad White. Remember, you can get more information right now by visiting medshoprx.com. That's medshop.rx.com. We'll be back with more of Health Matters with the Medicine Center Pharmacy in just a moment.
Are you sick and tired of waiting at the big chain pharmacies for your prescription? We've all been there. You aren't feeling well, and you go to pick up your prescription, you're told to come back later. At the Medicine Center Pharmacy, you don't have to wait. We can fill your prescription in 15 minutes or less, and we could even save you some money on your prescriptions. Talk to your Medicine Center pharmacist at any one of our locations in Canton, Louisville, Minerva, and New Philadelphia. Visit medshoprx.com for more information. You won't want to miss this upcoming Kiko Absolute Auction Tuesday, February 26th with auctioneer Bill Gill Jr. You'll find Victorian mahogany and marble furniture, antiques and collectibles, original signed paintings, as well as prints by Norman Rockwell, Baxter Cheeto, and others. You'll also find a beautiful collection of gold and diamond jewelry and watches from the Wanda M. Rafi estate, along with Hummel figurines, sports memorabilia, and more. Mark your calendar for Tuesday, February 26th at 3 p.m. at 3201 Parkway Street, Northwest in Canton. Call Bill Gill Jr. at 330-455-9357 or visit KikoAuctions.com.
With a heart attack, every second counts. Every moment the blood supply to your heart is cut off or reduced leads to heart damage or death. Mercy Medical Center can stop a heart attack in record time. Mercy is the only hospital in the nation that can open a blocked artery right in the ER just minutes after arrival, saving lives and preventing further heart muscle damage. That's because Mercy's Emergency Chest Pain Center was America's first to achieve full accreditation and the first to install a fully functional cardiac catheterization lab just a few steps away from our ER doors. The average time in the U.S. from ER arrival to opening of a blocked heart artery is 64 minutes. At Mercy, thanks to our ER cath lab and the area's most experienced emergency heart care team, it's faster. We're capable of opening a blocked artery in as little as 5 minutes. If you have heart attack symptoms, get to Mercy. We can stop a heart attack in record time. To learn more, visit cantonmercy.org/heart.
It's winter weather season, which means dry, irritated skin can be a problem. Medicine Center Pharmacy can help you stay moisturized for less. Save on our Quality Choice line of products during our buy one, get one free sale. The Quality Choice brand is the same as national brand items, but without the price tag. Stop into any Medicine Center Pharmacy and stock up on all Quality Choice products, including skincare, cold and flu remedies, feminine products, and more. Mix and match all Quality Choice and save big. Free item must be equal or lesser value. Visit MedShopRx.com for more information. Welcome back to Health Matters with the Medicine Center Pharmacy. I'm your pharmacist, Paul White. Today we're discussing neurosurgery with Dr. Rishi Goel from Aultman Medical Group. Let's get back to the last segment of the show. So, what about neurostimulators, pain pumps? And there's some of these things in sort of in the over-the-counter market now, I think.
There are. Those are not the same. Those are TENS units.
Okay.
So that's not the same, but we'll talk about that as well. So in
Okay.
terms of pain pumps, you can divide those into two categories. One would be a pump that delivers morphine.
Mm-hmm.
Another would be a pump that delivers baclofen. And the technology is the same. It's just the medication that's different. So if we talk about baclofen pumps, let's suppose someone's had a stroke, okay, and they have those chronic contractures where they're unable to move their arms or to move their legs. What a baclofen pump will do is that it'll deliver baclofen, which is a very strong muscle relaxer, directly onto the spinal cord, which allows them to relax and to, in some cases, regain some movement because they're so spastic. So it's used to treat spasticity in either patients with cerebral palsy or in stroke patients. And a lot of people don't know about that technology. The other medication that can be delivered through a pump are pain medications, so either morphine or Dilaudid. The reason why this comes in handy is that when medication like a narcotic is delivered from a pump onto the spine, it is 100 times stronger than the pill that you take orally. Okay, but because it's 100 times stronger than the pill that you take orally, that means that you can give a dose that's 100 times smaller than the pill that you take orally. So there's no addiction. There's no constipation.
So
there's no
when
euphoria.
you put that into the spine, it just kind of stays there? Is that what you're saying?
So the pump typically goes under the skin, and the pump is the size of a hockey puck.
Okay.
Okay, and there's a tube that goes from the pump into the spinal cord, and that's where the medication is released. So if let's suppose someone's had, massive back surgery or major abdominal surgery or cancer, and they have chronic pain, but you don't want to take the risk of them being addicted, or let's suppose they've been on chronic narcotics for a long time, to the point where the oral doses that are needed to sustain their pain, you're worried about them breathing. You can put a pump in them because you'll get a much higher concentration of that medication without the side effects.
So we were involved in this years ago. We did sterile medication, stuff like that, but the pumps were much bigger. They weren't under the skin, and you were able to pulse that pump if you needed an extra dose. Can we do this to the implanted pump?
Yes, Bluetooth is our friend.
Okay.
So you give the patient a remote for the pump. Now, the remote has lockouts, meaning that the pain doctors will set a basal rate, meaning that they'll determine what the patient's steady rate of medication delivery is, and then they'll allow the remote to, say, give an extra boost of medication, say, once every 10 minutes or once every 6 minutes. but not to exceed a certain dose. So all of that's determined by the pain doctors, but yes, the patients can get a remote, and they can give themselves an extra dose if needed.
Now, we only used morphine back in those days. Where'd baclofen? What's the?
So baclofen's a muscle relaxer, so that we'll use that in patients with cerebral palsy or stroke patients who are spastic. So they're just too tight; they can't.
So
move.
we're not looking for pain relief, but
right. Baclofen is strictly for spasticity.
But the I don't know what to say here.
But it can be used for pain relief as well.
Right, you can.
It breaks up this is simplistic. It breaks up the stricture of the
Correct.
something like
Correct.
that.
So if you allow those patients' muscles to relax, they're much
Sure.
more comfortable.
Sure. Okay.
So the pumps are good for either morphine to treat chronic pain, or the baclofen to treat spasticity. Now, neurostimulators is another piece of technology that we have for people who have chronic nerve pain. So this can also be in people who either have pain from, say, chemotherapy-induced peripheral neuropathy, which is basically, chemotherapy is poison, right? You're just hoping
Sure.
to kill more of the bad cells than the good cells. But sometimes there are side effects to that, and people can have pain in their legs. Or more commonly, what I tend to see are people who've had, say, major back surgery 5-10 years ago, and they have permanent nerve damage, and they have chronic pain. A neurostimulator can help alleviate those symptoms. So if you look at the spinal cord, and the spinal cord is running up and down our spine, there's a front and there's a back. Now, pain and temperature are on the front of the spinal cord. So if I poke you with the needle, that's the front of the spinal cord. If I bring a candle close to your skin, that burning sensation, front of the spinal cord. Touch and vibration, though, are on the back. The stimulator is an electrode that sits on the back of the spinal cord, trying to electrically stimulate the touch and vibration part of the spinal cord more so than whatever's stimulating the pain part of the spinal cord. So think about it this way. Let's suppose you walk into your living room and your stereo's on, and the stereo represents pain. So when you hear that stereo, you feel pain. Scenario 2, you walk into your living room and now the TV's on. The TV represents touch and vibration that the stimulator is turning on. Now in that second scenario, the volume of the TV is 10 times louder than the stereo. Which one are you going to hear? You're going to hear the TV. Now technically the stereo's on, but your brain can only process so much information at once. So if the TV is 10 times louder than the stereo, you'll feel a tingling sensation in your legs as opposed to the pain. So we're trying to drown out one signal with another, but we're trying to drown out pain with, say, a tingling sensation. So that's how the stimulator works. The good news is that you can test drive it. So before we put the permanent version in, the pain doctors will do what's called a phase 1, or a trial. And what they do is they put a small needle in the back, they slide the electrode through the needle, and under X-ray put it right about in the middle of the spine. They take the needle out, now you have a little wire coming out of your back. They connect that wire to a battery, they tape it to your back, and you go home. When you come back after about 3 or 4 days, they'll ask you, did you like it? If you say yes, they'll say, well, by how much did it help your pain? If you say more than 50%, you're a candidate for the permanent version, which I'll put in. If you say no, it didn't help by more than 50%, then it's not considered a successful modality for you. And then they just pull a little wire out and we try something else.
Okay. We don't have much time left, but I want to ask you this question. You've seen a lot of brains, okay? Albert Einstein, some of these people who claim to have been people who have used the maximum part of their brain, he's the only one I can think of. What's the deal?
So we're still trying to figure that out. I don't think structurally, they didn't have anything unusual with their brain, but they seem to have more dendritic connections, meaning that different parts of their brain were better at talking to each other.
I see.
And so that's something that we'll tend to see in musicians, mathematicians, people who read a lot. They're using more parts of their brain that talk to each other more efficiently.
Interesting.
When you were talking, I could be completely off base here, but does restless leg play?
No, unfortunately, it does not.
Okay.
It does not. So this would be for say, the neurostimulator for people who have like that chronic burning, shooting pain going down one or both of their legs.
Yeah. Gee, so many people seem to suffer from that.
Right, and a lot of people don't know about this technology.
Guess what? We're out of time. We never have enough time. Thank you to our special guest, Dr. Rishi Goel, neurosurgeon from Aultman Medical Group. We'd like to remind our listeners, if you suspect you have a medical issue, please contact your healthcare provider. Thanks to Studio Arts and Glass, Kiko Auctioneers and Realtors, and of course, JDR technical producer. As always, we thank you, our listeners, for joining us on Health Matters with the Medicine Center Pharmacy. We are a local Health Mart pharmacy, caring for you and about you. Have a healthy week. We'll see you again right here next Friday on News Talk 1480 WHBC.
Thank you for joining us for this edition of Health Matters with the Medicine Center Pharmacy and your hosts, your pharmacists Paul White and Brad White. Remember, you can get more information right now at medshoprx.com. That's medshop.rx.com. Be sure to join us next Friday at this time for Health Matters with the Medicine Center Pharmacy. The preceding program was sponsored by the Medicine Center Pharmacies.